Hi everybody, my name is Amit Jain. I am a Chief of Minimally Invasive Spine Surgery and Associate Professor of Orthopedic and Neurosurgery at Johns Hopkins.
Hi, my name is Akhil Chhatre. I'm the Director of Spine Rehabilitation and Assistant Professor at Johns Hopkins.
And today we'll be talking about collaborative treatment of back and neck pain and our philosophy at the Johns Hopkins Musculoskeletal Center to collaborate with each other to take care of your back and neck problems.
8 out of 10 Americans have back or neck problems sometime in their lifetime. It's the #2 reason to see a physician in the ambulatory setting.
At Johns Hopkins, at the Musculoskeletal Center, our mission is to identify the correct diagnosis when you present with either a back or neck issue, come up with the best treatment plan, whether it's a non-surgical treatment or surgical treatment as appropriate, and if surgery is chosen or recommended, then use modern cutting-edge tools and minimally invasive techniques so that we maximize your outcome and improve your recovery.
This is a snapshot of the general anatomy of the spine, and we're looking at it from the side here. And the spine is made up of several different areas. The cervical, which is also known as the neck, the thoracic, which is referred to as the mid-back, and the lumbar, which is the low back, and the sacrum and coccyx, which is the kind of the posterior part of your pelvis and your tailbone. The anatomy is complex, but they all interplay with each other. It's a 3-joint complex that we see here, and there's different segments that we see that are made up of the vertebral body, the facet joints, the spinous process, and we'll talk a little bit about some of the different pathologies that can come from these structures and what options we have for treatment and diagnosis.
One of the most common sources of low back pain is lumbar disc herniation, which basically means that the soft part of the spine may herniate out and press on the nerves. And as a result, you may have a pinched nerve resulting in severe pain like sciatica. The herniated disc can occur in any part of the spine, but the most common area it happens is at the base of the spine at the L5-S1 level. And that can cause severe shooting pain because the disc herniation is taking space and occupying the space that used to belong to the nerve.
There's a lot of terms that are used when describing low back pain, neck pain. People talk about disc bulges. They could talk about disc herniations, the different types of herniations, such as a protrusion, extrusion, or sequestration. These are ways to characterize the severity or to describe anatomically how these herniations present. Oftentimes people talk about sciatica, which is a generalized term to talk about pain that originates from a pinched nerve that might refer down the leg, and also a ruptured disc. All of these things are going to be described and talked about in detail when you come see one of our providers. A disc bulge is just a little bit of the disc presence beyond its normal margins. A protrusion, as you see here in this picture, is a broad-based extension of the disc material. An extrusion, as you see over here, is displaced disc material itself, and it's broader than the base, as this diagram shows. Sequestration is when some of the disc material has actually lost connection to the disc, so now it's isolated, it's kind of hanging out in this space away from the disc. When this irritation or injury can occur to the spinal nerves, as you see here, where the disc is coming out into the canal and rubbing up against that nerve root, it can then lead to pain. So some of the non-surgical treatment options with a provider like myself and in the MSK service line here at Johns Hopkins, we will talk about different options that we might have to help diagnose and treat these conditions. So we might talk about oral medications such as non-steroidals, nerve medications, steroids. These are all some options to discuss. They're not for everybody. It's the whole picture has to be taken clinically. The whole picture of the person has to be taken into consideration. We have to look at, what other conditions an individual might have in helping choose what's right for treatment. There are other modalities such as traction, physical therapy, chiropractic care, massage, acupuncture. What we do is we take a look at, what exactly is causing the symptoms, and we weigh what the utility and how helpful these options are. And we look at what evidence-based medicine shows as well. Interventional options, meaning we're doing something but non-surgical, would be things like epidural injections, facet blocks, rhizotomies, spinal cord stimulators. These are all options that we offer, and they can help with, one, the diagnosis of where the pain generator might be coming from, and also what it could be therapeutic as well. It might provide some pain relief for a select group of patients.
In some cases, despite of working extensively on non-operative and non-surgical treatments, the pain might persist and might be debilitating. Patients may develop weakness or they might develop inability to function or work. And in those scenarios, depending on what the MRI shows, surgery may be indicated. And surgery can be successful and generally performed on an outpatient basis where you go home the same day or after a brief stay in the hospital just overnight, depending on a variety of factors. And this is what the disc herniation, disc material might look like. So it's actually real hard material that's pressing on the nerves that's removed. Now, the next condition that can occur for which we frequently see patients is lumbar stenosis. And lumbar stenosis is a condition that refers to a narrowing of the space available for the nerves. So in addition to the disc herniating, you might develop arthritis or other degenerative changes which may narrow the space available for the nerves. The analogy I like to use, it's like going down Highway 95. So instead of having a 5-lane highway, if it gets shut down for whatever reason, and now you only have a 1-lane highway, that's the same analogy for lumbar stenosis. So nerves just don't have a lot of room to travel and they get very upset. It's hence some combination of degeneration, whether it's a disc problem or a facet problem, that leads to compression of the neural elements. A lot of different ways this can present. It can present as back pain. It can present as buttock or thigh pain, as leg heaviness, or shooting pain down the legs. So many causes.
There's many causes. You see some examples here. Arthritis or spondylosis, which is a medical term for arthritis of the spine. Lumbar disc degeneration, so wear and tear that occurs between the vertebral body and the discs. Facet hypertrophy, so facet is a general term used to describe the two posterior joint complexes in the back column of the spine. And when those enlarge, they can occupy space, just like joints can in your fingers. When they get arthritic, they get large. Similarly, when they enlarge in the spine, they start to encroach upon space that was normally occupied by the spinal contents itself. Ligamentum flavum hypertrophy, so that's one of the ligaments that makes up the part of the anatomy of the spine, and that can sometimes get thickened and can cause stenosis as well. Lumbar disc herniation, so when the discs that Dr. Jain had given an example of earlier, when they come out into the space in the canal, they can occupy space. Synovial cysts, so just like we can get cysts in other parts of our body, like the wrists or the knee, we can get a collection of fluid that arise from the joint complexes in the spine. They can occupy space. Epidural lipomatosis is a collection of fatty tissue that can occur in the spinal canal, or just congenital. You're born with a naturally smaller canal diameter than your average Joe or Jane. And these are just some examples.
One of the issues this can cause is trouble with walking and ambulation. So you might require assistance with walking, and for example, going to the grocery store might require a grocery cart to walk. You have trouble standing up straight, trouble walking for more than a few minutes, trouble walking around the city block. These are all hints that your body is giving you that you might have spinal stenosis. There are the three S's we like to talk about, which are spondylosis, spondylolisthesis, and spondylolysis. These are fancy words that basically describe what's happening to the spine and why the stenosis is being created, whether it's spondylosis, which means spinal arthritis, spondylolisthesis, which means that the bones are moving with respect to each other, and therefore the stenosis is being created, or spondylolysis, which means that the bones are cracking or there's some kind of a breaking in the bones, and as a result, the stenosis is being created. MRI can be very helpful in coming up with the etiology or the reason for why the stenosis is present.
And even in these settings that we could talk about what the non-surgical options are. Similar to what I discussed earlier, we can observe. There are cases with stenosis where people present where action is not required. Sometimes it's important to identify and diagnose and help come up with a treatment plan should things occur down the road. Physical therapy and exercise is a very important part of what we want to provide for our patients. It's important to carry ourselves in space properly. What are the right biomechanics? What things should we do and not do? And then what kind of exercise program is beneficial and helpful with the conditions that a patient might have. We did talk about oral medications. Some medications are more helpful in the setting of stenosis versus radiculopathy or other conditions. And then injections, there are specific injections and interventions that we can provide for stenosis versus other diagnoses.
And then surgical treatment is an option as well if the non-surgical treatments are not working the way we hope that they would. Surgery can consist of big open surgery or minimally invasive surgery. One of the things we believe in at Johns Hopkins is try to reduce the damage to the body during the process of surgery. And the way to accomplish that is through minimally invasive surgery, where we use modern techniques and limited exposures to take care of the problem and reduce the damage to the body. One of the ways we have done that successfully is pioneering use of robotics for minimally invasive spinal surgery. We are one of the few centers in the country that has this capability and is able to really get patients up and about very quickly, even with complicated operations like spinal fusion with use of advanced technology like robotics.
Do want to transition now to neck pain and how people present if they have, for example, a pinched nerve in the neck. Pinched nerve is called a radiculopathy. And if it occurs in the neck, we call it a cervical, which is the medical term for neck, radiculopathy. And that can present with pain in the neck. And if it's sharp shooting down into the extremity, into the hand or the forearm, it's oftentimes the forefront of our suspicion of whether that is the case. As you see here, again, we have another diagram of a disc that is herniated and protruded. It's disc material and it's pinching a nerve root as it's exiting the spine. There are pathways that we use to help identify this through things like getting MRIs and a comprehensive physical exam and a robust history. This is part of what you can expect when you come to the MSK Center here at Hopkins.
And as Dr. Chhatre mentioned, the compression of the nerve roots can be from the disc herniations or from bony fragments that are sitting on the nerve. It can create a variety of pain patterns, including pain down your shoulder, pain down the arm, the forearm, pain into the fingers, the index finger, or any of the other fingers, or pain along your elbow region, and as well as along your scapular region, so between your shoulder blades. So all of these are signs the body's telling you that you might be having a neck problem, and as a result, cause electrical pain down the extremities. In addition to this, in some circumstances, the situation is worse, where the pressure is not just on the nerves, but on the spinal cord itself. And as a result, the spinal cord might be getting damaged. And if that happens, that's called cervical myelopathy. Interestingly enough, this condition can also occur where there is no pain, but there are more subtle issues like trouble with balance, trouble holding onto objects, trouble dropping things, difficulty with buttoning your shirt, difficulty with writing and holding a pen. All of these things might be signs of myelopathy and you may have potentially no pain because it's just pressure on the spinal cord, but the nerves themselves are not acting up.
Non-surgical treatment in this setting includes several of the things that we see on the screen here. So first line would be rest. Was there some type of trauma, some type of inciting event? How can we halt any type of progression? There's medications that we can provide to help with the symptoms themselves, the non-steroidals that we discussed. Steroid dose packs can help. Nerve pills like gabapentin or muscle relaxers. We take a multidisciplinary approach. So at the same time, based off of the working diagnosis, we'll talk about physical therapy. We could focus on traction to reduce pressure on that nerve root. What kind of isometric exercises can we do to help not only relieve pressure, but strengthen the support system for the cervical spine? Chiropractic treatment and acupuncture can be helpful as well, and we offer those here at Johns Hopkins. Second line treatment would be epidural steroid injection. So can we go right to the hot spot where a lot of this inflammatory, noxious occurrences are happening, and can we give some medicine to help kind of calm everything down?
And in certain cases, despite of exhaustive non-operative treatment, the symptoms might persist, or the damage to the spinal cord or the nerves might be too much, where we decide that surgery might be the better option. And that's what we would recommend. Surgery can occur from the front of the neck or the back of the neck, depending on a variety of different criteria and considerations. And in some cases, surgery can be motion preserving. That means despite of doing surgery to the neck and putting metal in the neck, you still retain most of the motion inside your neck. And we can make that determination when we evaluate you. In summary, our philosophy is to work collaboratively between non-operative and operative providers to come up with the best outcome for you and your loved ones. For appointments, please call the Johns Hopkins Musculoskeletal line at 443-997-6754. Dr. Chhatre, myself, as well as other Johns Hopkins spine providers are here to take care of you. Thank you very much.
Thank you.